Hi, everybody. It's Scott here, and this whole presentation is basically an A to Z on setting up your vent and doing some tweaking. So, um, hopefully, you got a little bit of time to watch through this. Maybe watch part of it, come back to it. Take about 40 minutes, I expect. So, let's go through and see what we can do to increase our knowledge of taking care of setting up people on the ventilator and making sure our settings are correct. So. Let's start off with why would we want to use the ventilator, and that's an easy question for me. And one is the BVM is just really inconsistent. Variability from user to user. You don't know what your tidal volume is going to be. You don't know how good the seal towards the face is going to be, and you have to use airways with this. And trying to hold that seal with the airways, it's just difficult to get the lungs to rise. In addition to that, the BVM, unless you've got a PEEP valve on there, doesn't offer any exhalation resistance. So lungs completely collapse after the ventilation is on exhalation and waiting for the next breath. So you're constantly trying to reinflate the lungs that are collapsing and sticking to themselves. So it shouldn't be a hard argument to get someone convinced that using the ventilator is a lot better idea than staying with the BVM and just BVMing, a patient for, 20, 30 minutes on the way to the hospital, if that's the case. Now, there's also a way to take advantage of the ventilator and utilize the mask if the patient's not intubated, which, sometimes can be quite helpful. And it's definitely helpful in the pre-oxygenation phase of prepping to intubate your patient. And that's just hook up the vent and turn it on and put the mask on the tubing, put it on their face, and hold a seal with oral, nasal, or both airways in their mouth and nose, and then use both of your hands to hold the ventilator mask against their face, and you can actually get PEEP and let the ventilator pre-oxygenate your patient for you while you're using both hands to hold the seal, and you can get such better pre-oxygenation effectiveness by using that method. So we're going to talk in this talk about both AC mode and using BiPAP. We'll talk about BiPAP more towards the end. But right now, let's talk about assist control. Sometimes this is confusing to folks, but basically with assist control, we're going to set up the ventilator so that the ventilator is really independent. It's going to be doing whatever settings that you set for it, and if the patient wants more as far as a rate is concerned, they can get it, but oftentimes with assist control, we find patients that are trying to breathe at right around the same rate that we've got assist control set, at the same breath rate, and that's where we get them bucking the vent, and that can be difficult. If they are driving to breathe and you only have assist control, and they're bucking the vent a lot and do have a good urge to try to breathe on their own, you can try turning the ventilatory rate down in assist control and see if they can actually exceed the rate that you set. I just want to set it that low. I'd probably set it about 6 to 8 breaths a minute and see if they can overcome that, because they can initiate their own breath. And provided that those breaths are, being supported by the vent, and those breaths are adequate and oxygenation is still taking place, then I'd probably just go with that. If that's not possible, then you may have to just provide more sedation and pain control so the patient is able to tolerate the assist control. Because I can imagine if a patient is very alert, that if the ventilator is giving them a breath and it's on exhalation, but they want a breath, and they're back and forth fighting, that it can be very frustrating for your patients. So try to do a good job of making sure they don't remember this, and give them some sedation, pain control, whatever your protocol dictates, so that they're much more comfortable on this. So if you have the ability to do synchronized intermittent SIMV ventilation, and that goes along so well with patients that are actually driving to breathe on their own. It's just not adequate depth or maybe an adequate rate, but the ventilator is kind of more paying attention to the patient and going to supplement those breaths that they initiate and get them a rate and depth that they actually can coordinate with. So it's really a great mode of ventilation if your patient has a drive to breathe. So I didn't say much about switching over to pressure or volume from assist control, but generally most accepted mode of ventilation and assist control is pressure mode. You set the tidal volume, and that tidal volume is given to the patient, and we're using about 6 to 8 mils per kg. I like to recommend starting on the low end and working up until you see a resulting PIP that you think is adequate and you've got good lung sounds and good chest rise. However, in effort to promote patient safety, then you could put it over into pressure mode and then set the PIP to what you want to limit it to, and that might be anywhere from 20 to 35, whatever the lungs that you have tolerate or what they're required to get the decent tidal volume. More restrictive lungs like COPD lungs, they're going to get a higher PIP. But when you set that PIP in AC pressure, then it's going to target that PIP, and then you can see a resulting volume of what it's giving and just make sure that's adequate. And sometimes that is the best way to go. So, and then the other settings are all the same. The IE ratio and the respiratory rate are all the same. So when I'm set on the vent, right after I turn it on and I get to the mode that I'm going to, which is for me in the field is generally an assist control volume mode, I'm going to estimate what I think their tidal volume is based on how tall they are, and I'm going to undershoot just a little bit because I can titrate up without ever having put the patient in danger of a high tidal volume. You should think of tidal volume as protecting their lungs. You might hear people talking about PEEP, and PEEP can result in pneumothoraces, but that is absolutely not true. High tidal volumes are what cause damage to alveoli and damage to lung tissue. So you always want to start a little bit low because you've got you can take a few breaths to get that tidal volume increase so you can see what the PIP becomes with each change in tidal volume. So you can estimate 6 mils per kg if you want, and every time it gives a breath, you want to see what that PIP is, and then listen to lung sounds. Make sure you got good capnography. Make sure the chest is rising. Make sure the lung sounds are equal. So if you look at the graph down here, you can see the PEEP is all on exhalation, and that's just the pressure that's left over in the lungs. And then we give a breath, and we reach this peak pressure, this peak inspiratory pressure, and that right there is honestly a result of the rush of air that goes into the terminal bronchioles and hits the alveolar duct. When it hits the duct, there's a resistance, and that resistance gives us the highest pressure that we realize in this respiratory cycle. And shortly after it hits that alveolar duct, air is continuing to rush into the alveoli, which are much bigger than the alveolar duct. If we were able to measure this, and in some of the ventilatory functions, you have a ventilator that measures plateau pressure, which is actually measuring the inspiratory breath longer than a moment. It's measuring over a second or two, and what that does is it actually reaches a plateau as we measure what pressure the alveoli are getting, which gives us a level of safety. Because the PIP could go very high, but then that pressure is never realized in the alveolus. But if I measure over time, I can see that you've got a plateau pressure. I can tell what the alveoli are getting, and that is a hardline number. We want to keep our P-plats less than 30 centimeters of water. That's how we're setting tidal volume. If your patient's not oxygenating, we have other ways of tweaking the vent to get those settings or get the patient's oxygenation levels up and to make sure that it's adequate. But tidal volume is really not something that we can modify very much. You can't change the volume of somebody's lungs. You can change how fast the flow goes in or how fast it's coming out per se. With what pressure, you can change certain things. You can change the rate of ventilation, so you can change a lot of things, but you can't change their tidal volume. Quite specifically, the only time you're going to change tidal volume is, you can make it larger or smaller, but you aren't really in control of that. Their lung volume is their lung volume, but it can reduce if they got a developing pneumothorax. Hopefully it's not developing into a tension before we catch it, and notice that there's an increased PIP because the lung volume is decreasing with every breath. If you were giving a bronchospasm therapy with a beta agonist, you're giving your albuterol and your Atrovent, and you're actually opening the patient up by doing this in line, and they're bronchodilating, well, then you would increase your tidal volume, and that's one of the few times it's actually going to get larger. And if that does, then the tidal volume they're giving is going to result in a lower PIP pressure. It's wonderful. You should be able to see the changes on your capnography, which go from a more bronchospastic waveform, the upsloping shark fin looking waveform, to a more boxed waveform. And that's great, because if that happens, then I've got an opportunity to safely increase my tidal volume a little bit and get back to the PIP that I'd set initially, and continue to recruit more and more of those lung fields, and let the medication work to recruit all the lung fields so I get good diffusion of oxygen with every ventilation. So hardline, if you've got ability to measure plateau pressure, then you want to do it less than 30. You want to listen to breath sounds always, and you want to make sure that you're getting as much recruitment of the alveolar surface area as you can. Now, one other consideration, if your patient is a septic patient, hopefully you haven't had to intubate them, but obviously if you're thinking about this, then you've had to intubate them. We want to try to stave off intubation on septic patients in general. That's a whole other category or topic of conversation, but in general, we want to do fluid resuscitation, levo-fed, do all the things, non-invasive, high concentration of O2. We want to avoid intubating our septic patients because their mortality is increasing greatly once we have to medicate them, intubate them, and get to that level. The mortality is very high. So, but if I do end up having to intubate the septic patient because they weren't fluid responsive, I couldn't get their pressure up adequately, they couldn't oxygenate them, then with respect to tidal volume, I want to keep their PIP low, and I want to be cautious about my PEEP, and I'm going to continue to give them fluids. I'm going to be earlier in giving my levo-fed. I'm going to be a little bit more aggressive in turning up the dose of my levo-fed to get adequate blood pressure and perfusion to my vital organs, to the brain. But I'm not going to be aggressive when it comes to increasing my pressures on my tidal volume whenever I know I have a septic patient. All right, so the next thing I said, I've got the ventilator on. I've set my tidal volume. I titrated it up to get a decent PEEP that I feel like is adequate. I've assessed the lung sounds. I've listened to all the fields. Then I'm going to set my respiratory rate. Generally, I'm just going to set this based on whatever my EtCO2 is. Now, if my end tidal is between 40 and 45, I'm probably going to leave that respiratory rate alone and just watch the trending value of my end tidal capnography. If it starts to trend down, gets below 40, I'm going to watch pretty close. I may start taking my respiratory rate down a little bit because we're more comfortable leaving our patients in the upper range of end tidal, which leaves some more dilated vasculature so that we get good perfusion to the head, especially, rather than having a low CO2, which promotes constriction. So titrate your respiratory rate carefully. If you bump that respiratory rate up more than a couple breaths a minute, and I limit myself to, if I've got a rate of 12 and I want to bring that CO2, that's 50, 55, or 60, and I want to bring it down a little bit. If I got a rate of 12, I'm going to bring it down to 4. I'm going to bring it up to 14, and then I'm going to wait 5 minutes and see what happens because I'm not freaking out about a CO2 50 or 55 because I can gradually bring that down. What I don't want to do and what I try to avoid is bringing that respiratory rate from 12 to 16 in an effort to bring that CO2 quickly back down to the range, because often what can happen in that situation is you're going to lower the CO2 so much that now you've got to change your respiratory rate drastically back down to 10 and try to let it come back up and fall within the range. And that seems to happen a lot slower than it is to blow it off in the first place. So if you wanted to calculate some parameters for your respiratory rate, you can definitely titrate by CO2, and that's probably what most of us are going to do in the field realistically, because we're not going to do a bunch of math in the field. But if I wanted to kind of look at this, if I know what the tidal volume is, I can calculate 120 mils per ideal body weight. So 120 mils per kg if I can figure their ideal body weight, and it'll take a chart for me to figure that out with most patients. So take their ideal body weight and multiply it times 120 mils and divided by whatever the tidal volume is, and it gives me a respiratory rate for a minute volume, basically. And so I know that that's probably my upper, or roughly my upper respiratory rate that I would use. And so I'm going to use that in combination of, well, what is my end tidal CO2 to set my respiratory rate. So that's one of the ways that I'm going to kind of calculate what my respiratory rate is. And you're going to titrate that and tailor it specifically to what your patient's CO2 is and what their needs are. So with respect to triggering, if my patient's trying to take a lot of, and this is generally true with all your head injury patients, if they got neurogenic hyperventilation, if they have BIATs or Cheyne-Stokes respirations, they may be taking very small ineffective breaths and just driving this ventilator very quickly and blow off a lot of CO2, which I know I don't want to do that. Definitely in a head injury patient, I don't want to get low CO2s in head injury patients. I need perfusion to that brain because it's already in trouble. So if I change the trigger, and on the Zoll monitor, which I'm most familiar with, I can hold the PIP button down. Your trigger may be wherever on your vent. Just find the triggering And what that is your patient takes a negative 2 centimeter water inhalation, and the vent will give them a breath. If I don't want them to generate that, and because they're sucking on the tube and they're pulling these little breaths that are very ineffective, but they're generating volume and it's moving lots of air, I might want to raise that trigger up. I'm just maybe go up to -3, -4. With that, though, I would offer a little bit more sedation. Make sure your patient's not realizing that they're sucking on this tube and trying to get a breath and they're not getting one. That's probably very miserable. So I'm very cautious about raising the trigger, but if the patient's blowing off all their CO2 and I need to get control of that, then I will sedate them a little bit, keeping their blood pressure in mind. But raising that trigger slightly might keep them from taking those very small breaths and blowing off CO2. So if the patient's having trouble getting a breath, that's more of a BiPAP thing, where I change the trigger and make it less sensitive so that they can get an easier breath. But we'll talk about that momentarily. All right. PEEP and oxygenation go hand in hand. PEEP is where I'm going to, if I've got a patient, I set my tidal volume, I've got 100% FiO2, and I still don't have a patient that's satting well, especially it's very low, 70s, 80s, then my PEEP needs to be increased. And the whole idea with PEEP is it's going to allow, instead of just giving a breath, like imagine a BVM just has the breath going in and then it comes right back out. It's a very short amount of time that the air stays in contact with the alveolus. The oxygen has to diffuse in that quick moment in time as the air is rushing out. PEEP extends that time. It holds that pressure inside the alveolus and allows time for the oxygen to diffuse. So if I've got a patient that's hypoxic, it's not a matter of ever increasing my tidal volume. It's not a matter of increasing the rate of ventilations. It is a matter of FiO2 and PEEP. Now, physiologic PEEP is 3 to 5. I can use PEEP as a therapy to oxygenate patients, especially if there's a fluid pathology, pneumonia, bilateral pneumonias, any kind of pulmonary edema secondary to near drowning, even those hypoventilating patients that have been on some sort of alcohol, benzos, opioids, whatever, they've been hypoventilating, they got a lot of pulmonary edema that could easily be blown back or pushed back into the vascular system. A little bit of therapeutic PEEP is going to be a good thing for them. And I might be able actually to lower it once I get their lungs cleared up. So definitely a good thing. If you see that frothy stuff coming up their tube right after you've intubated a patient, immediately in your mind, you should be thinking, if I got a bunch of froth, suctioning that, you'll never keep up. So you can try tracheal suctioning. You are never going to keep up. Just get them on the vent as quick as you can. Crank that PEEP up, maybe to about 8 or 10, and get them ventilated, because the PEEP is the only thing that's going to push that back across. Otherwise, you're going to find yourself suctioning and suctioning and suctioning, and your patient's going to crump on you because you're never oxygenating them and you're never getting ahead of that froth that's coming out. So as soon as you see froth coming up the tube, the next time you see that, you should think, we need to get them on the vent, we need to get some PEEP on them. And you'll find that your patients do pretty well. So as you get the PEEP up and they start to oxygenate well, once you get close to that pulse ox that you're looking for with a good waveform, then start bringing your FiO2 down. Because once you've used PEEP to get that oxygenation level up, then you can start bringing the FiO2 down and you can start working them together. And you're going to titrate your oxygen level to your FiO2. You're going to titrate that down as low as you can get by, and your patient keeps those good sats. Now, if you've used so much PEEP, say you've gone to 10 or 12 and you finally get your patient oxygenated, don't ever take away your PEEP just because your patient's blood pressure started to tank. If their blood pressure started to get so low because you used PEEP to oxygenate them, well, you had to oxygenate them in the first place, or otherwise you have nothing. So support their vascular side with fluids and pressors if necessary. Do not take away your PEEP because their pressure changed. Okay, you'll turn that PEEP up, you get good oxygenation, next thing you know, take a blood pressure and the blood pressure's down. Just support that blood pressure with IV fluids. Make sure you get 2 lines, get some Levophed on board, start low, work high, make the patient, you do what the patient makes you do, but don't take away the things that you did in the airway to get your patient oxygenated, get good lung recruitment. Don't change those things. Just support that vascular side. All right, so an important setting in patients that you intubate that have bronchospasm, so your asthma, COPD patients, if they're wheezing, you are giving breathing treatments, albuterol, Atrovent, and they didn't get better. They got so fatigued that you had to intubate them. Well, hopefully you didn't, but if you get to this point, now we're on the vent. First and foremost, try not to forget to keep giving that breathing treatment. If you haven't put together an inline breathing treatment, used a 90-degree elbow coming off the tube, putting it together with the vent tubing, then you might want to get those pieces out and make sure you know how they fit together. On the ventilator, I'm going to set my settings very similar to my normal AC mode. Tidal volume is going to get there by PIP. I'm setting my respiratory rate. And now I'm going to set my respiratory rate very low, because now I've got to consider my IE ratio. This patient's having a hard time breathing out. They're bronchospastic. Got to get that respiratory rate low so that I can adjust my IE ratio. Now, my IE ratio is very important in this setting, because now that I'm blowing certain volumes of air in, I've got to give them time to get those out. So if I increase my IE ratio and I lower my respiratory rate, what I've done is I put my respiratory rate at 10 usually. That gives every breath, the whole breath from inspiratory to exhalation, is going to be 6 seconds. Now, if you look down on your ventilator and you see this TI, this inspiratory time, at this IE ratio of 1 to 2.5, 1.14 is how many seconds it's taken to give that breath. As I increase my IE ratio, basically what I'm doing is I'm taking some of the inspiratory time and I'm giving it to the expiratory time. All right, I'm taking some of the inspiratory time, I'm going to subtract a little bit of this inspiratory time, and I'm going to give it to the exhalation time. So whatever I set this at as far as breaths per minute, I'm dividing up inspiratory and expiratory in that cycle of respiration. So if I got a 6-second breath period of time, and I set that rate of 1 to 5 for inspiratory, expiratory, then I got one breath in 1 second, and the rest of that's 5 seconds. So you've got to increase this IE ratio on your bronchospastic patients. Otherwise, you get an incomplete exhalation alarm, and there's only 2 things I can really do with that. 1, I need to pop that ventilator off the tube just for a second and let the pressure equalize. 2, I got to increase IE ratio if I forgot to. If that doesn't work, I've got to lower the tidal volume. Now, this particular example is set in pressure mode, so I would have to be in volume mode to change that. I would change and lower that tidal volume if I've got an incomplete exhalation. All right, so that's my only 2 moves that I can really make. So very a life-saving setting for the bronchospasm patient. If they ever get so bad and you didn't catch this and your patient went into arrest, I can tell you that most generally, if it's not a tension pneumothorax, you've just increased the inner thoracic pressure so much that they weren't getting enough blood through the vena cava back into the right atrium, and their cardiac output suffered for that. And you got to take that vent tubing off their DT tube, start compressions if they have no pulse, work your PEA algorithm, but check them back often so that you can see if you've got a pulse back. You expect those patients to turn around pretty quickly. Okay, so get that vent tubing off of them and get compression started. And if you're going to if you get ROSC and you put them back on the vent, you've got to lower that tidal volume and increase that IE ratio a little bit more. All right, so recap on AC mode. Tidal volume rarely changes. You got to monitor it. I don't know if I said this or not earlier, but once I set the tidal volume to a volume and I've got a PIP, and if I'm running at a PIP of say 20, then one of the things I like to change that upper alarm limit and get it down to about 5 centimeters of water above whatever my PIP is trending at, so that if I get a pneumo or a tension pneumo, or if I get a kink tube, I know a lot quicker than if I leave it at 35 where it comes on. So watch my end tidal for my respiratory rate, set the end tidal, and target that end tidal by setting your respiratory rate. Okay. Next, PEEP is going to help with oxygenation. That is the thing. Don't change your tidal volume. Don't change your rate. Change the tidal. Change the PEEP if you need to oxygenate your patient better. Get them to 99 and keep turning that FiO2 down until you can make sure that patient's not at 100% on their SATs, because we don't know how far past that 100% that they are actually if we do a blood gas, and we can't do that in the field. So don't forget the IE ratio on the bronchospasm. You need to increase the IE ratio to 1 to 5, 1 to 6. Drop your respiratory rate to 10. That way you've got a longer span of time from inspiratory to the end of exhalation. All right. Trigger and be adjusted. I just caution you, with your patients to not raise that up very much. Just use it as a tool to keep them from taking those small breaths if they're trying to initiate breaths that aren't effective. All right, listen to breath sounds. There's not a thing that has been put out scientifically, technology, that can replace your stethoscope. If you got a patient that has a lung down, you got to find it this way. They will possibly set off an increased pressure alarm or a PIP alarm, but you got to listen to see if you're getting good lung sounds or recruiting the bases. So that definitely listen to your lung sounds. So let's change gears for a minute. Let's go talk about BiPAP, bi-level ventilation, the non-invasive. This is our go-to for our hypertensive CHF patients. We're using it more for our COPD patients, trying to drive the medicine down in their lungs a little bit better. So it's used for just about any fluid-related pathology. All right. So setting it up is really easy. We're going to turn the thing on, turn it to a bi-level mode, and I've got another video showing how to set this up. If you look on my channel, it's pretty easy to find how to set up BiPAP on the Zoll ventilator. And turn it on, set it for BiPAP, set your pressure support to 10, set your PEEP to 5, start there, and start watching. Hopefully your patient get better. I've got some pieces of advice. These are more my opinion and practice and anecdotal evidence. Is one, if your patient's not tolerating the mask very much, then get down there with them and talk to them calmly, talk slowly, and encourage them that they can do this, holding the mask to their face and holding your hand on the back of their head. Use that mask, talk to them a little bit, say just take a deep breath for me and work with it. They get panicked, take it away for a second. If you can get it back on there, work with it. So until they can get to where they can just constantly hold it on there. And some patients will get so good they can actually just hold it to their face, and they'll do really well all the way to the hospital. Now, where it says triggering, this I find to be very, very helpful. Now, in patients that are driving to breathe, they're not tired, they got in trouble, but they haven't fatigued themselves so much before they called 911, then those guys do pretty well on the sensitivity setting of -2. That means they've got to pull, a breath in at -2 centimeters of water to get a breath. If they can't do that because of low lung capacity at that point, because they got CHF so extensively that they don't have a lung volume that's left, or if they got COPD and they're so bronchoconstricted, or their muscles are just fatigued from trying to breathe so hard for so long, you may want to bring that trigger down. Try bringing that trigger down. In our machine, it's you hold down the PIP and you see the trigger. It's a -2. Just turn down to -1. I've had to turn down to -0.5 to get patients to breathe right or to be able to generate a breath. And you actually might start getting them out of trouble. Now, just make it easier for them to initiate that breath from the machine. So if they can't generate -2 centimeters of water, the machine's not going to do them any good. And we've probably intubated a lot of patients because bi-level apparently failed, and really it's just a matter of they couldn't generate enough negative pressure to trigger a breath. So I want to mention also, if you're doing this for CHF, being on guard with the nitro and getting it on as soon as you've made the field diagnosis of CHF, hypertensive CHF, the nitro is actually what's going to save them for the most. The BiPAP is definitely a huge therapy, is helping with that, and increased thoracic pressures are going to help lower blood pressure a little bit more, but you got to keep giving them that nitro. If you got a nitro drip, it's even better. All right, keep on that, because lowering the pressure is going to blunt making them getting worse. It's going to allow the lower pressure on the vascular side so that the increased alveolar side from the BiPAP actually gets to work and push fluid back across. So super important. Get the nitro on board. Continue giving it. If you have paste, use paste. If you have a drip, definitely use the drip. All right, because we're going to increasing interalveolar pressure. All right, and interthoracic pressure. There's plenty of folks that have talked about it. Well, what's making people better in BiPAP? Well, if you just use BiPAP on a hypertensive patient, they are not going to get better and stay better. You take the BiPAP off, they'll be right back where they were. So nitro is really the #1 therapy that they need. You've got to get that blood pressure down. We got to manage that blood pressure. For whatever reason, it got high and the left ventricle couldn't handle it. So it got so high that the backflow is in the lungs, and we're putting increased pressure in the pulmonary space in the alveolus. And we've got to increase that with BiPAP, but we got to lower the vascular side with nitro. It's magical. You can make people better so much faster if you're aggressive with this. So It'll help push the fluid across. It increases their tidal volume. Then we just want to maintain that low blood pressure. Once we get that all pushed out, for the most part, your patient's going to breathe so much easier, and they're going to look good. And you're going to feel like you really did them a huge favor. So aggressive with the nitro, aggressive with your BiPAP. Start at 10/5. Now, I didn't talk about tweaking the BiPAP a little bit. I get kind of a couple categories of patients. One already talked about triggering. So basically, I have 3 things that can go. Patient can't initiate a breath. Well, lower the trigger, make it easier for them to breathe. If they feel like they're not getting enough air, well, the thing you need to adjust, if they can't get enough air, then increase their pressure support. If it's at 10, you start at 10/5, like we start with most patients, and turn it up to 12, maybe turn it up to 14 or 15. Just bring it up and see if it makes them feel like they're getting enough air. Right? That's how you give them more air. If the patient's not oxygenating well, if over time, set it at 10/5, they're not oxygenating well, and I'm at 100% FiO2, then bring up the PEEP. If the PEEP's at 5, bring it to 7, maybe 8. Then that doesn't work, maybe 9. Just keep elevating the game until we get to the point where they're oxygenating better. And they may not oxygenate better if you're not doing your nitro like you're supposed to get on the nitro. If their blood pressure is high, you're not going to make them better with just BiPAP. Give them nitro. Get their blood pressure down. Get the blood pressure down, you can give them PEEP to get them cleared out, and you can probably bring that PEEP back down after they're cleared out, and they'll still oxygenate better because you've given them more surface area. So lower blood pressure, increase alveolar pressure, you're going to make people better. All right. So just to end this up, choose a proper mode of ventilation for the patient. We just talked about basically AC mode for intubated patients. They're sedated, pain controlled, and everything. They're on an ET tube. You start out with 100% and then drop them down. My patients that don't have lung disease, after I get them oxygenated well, I'll drop them down to like 40% and then titrate. If they don't need any oxygen therapy on top of that, they just needed ventilation, I'll keep dropping them down. I may get to atmospheric 21%. If they need more oxygenation, I go back up. Patients that have lung diseases or lung pathology that I'm aware of, then I might drop them from 100% down to 60% and then titrate them from there. So otherwise, I'm just titrating oxygen like the drug that it is. So start with a good tidal volume that's low, work your way up, target your PIP, make sure that your patient's safe. Okay, that's where you're creating protection for your patients. Adjust respiratory rate based on their end-tidal CO2. Careful, don't adjust the respiratory rate more than 2 breaths a minute until you get to the target that you're looking at. If you got those ROS patients that you've intubated and their CO2 is really high for a moment, just keep ventilating them at the rate you were and see what it comes down to, because I guarantee with a good tidal volume and a respiratory rate that's fairly normal, 12 to 14 or 16, you're going to have an end-tidal measurement that's probably going to be pretty adequate if you wait about a few minutes. Just let it come down. Don't get aggressive and start cranking it up on the respiratory rate until you see what it's going to do in 5 minutes. So give them a little bit to kind of recalibrate a little bit. If you've got bronchospasm, don't forget to increase the IE ratio. Go to 1:5, see what you need. Lower the respiratory rate to 10, increase that time that we're dividing up, and make sure that they don't have an incomplete exhalation. If they do still have an incomplete exhalation, lower the tidal volume a little bit. Lower it 20 to 40 mils with every tidal volume, so with every breath. Adjust your alarm limits and get them closer to what you're trending at so that you know what's going on a little faster. This is a tweak that you do after everything is set, you're looking good, then just set your alarm limits. Okay, this just makes us a little bit more aware of what's going on as a patient that looks like they're doing fine. If something should happen, I want to know immediately. So continue to provide your albuterol Atrovent for your patients with asthma and COPD after you intubate them. Sometimes we get such a hurry, it's hard to remember that. Try to remember to do that. If you haven't put it together in a while, go put it together. Make sure you know how in an emergency. Okay. Tweaks, triggering, we talked about that a lot. Tweaking all these little settings. We have basically 4 or 5 little things that we can tweak. I mean, add FiO2 in here. We can handle this. You know, initial setup, tidal volume, respiratory rate, FiO2, PEEP, IE ratio. It's not a long list of things. Everyone has their job, and titrating those little things is all individual, patient to patient. For the most part, to summarize this, when you're in AC mode, you're going to set up your ventilator starting at the same place for most of your patients. But I'm going to tell you, it takes sick lungs and over and over and over using this ventilator to get good at it. We've got to use it, and I can't tell you where you're going to end up on your tidal volume or respiratory rate or your FiO2 or IE ratio. But you will find out as you adjust these things to tailor to your patient's needs, you'll get it figured out eventually, and all your patients will have individual vent settings because all of your patients are a little bit different. So I hope this has been helpful. I hope that if you didn't get some of this, you'll go back and listen to it again when you get some time, because we can get good at the ventilator. We just got to practice, and you can make your patients better and keep them better if you use good strategies. So thanks for watching. We'll talk to you later.